Good afternoon, and welcome to all of you. Thank you for joining us today for the Verne Gallman Distinguished Lectureship in Nursing. Of all of our events at the School of Nursing, I think this is one that we as faculty hold as perhaps the nearest and dearest to our hearts, with the exception, of course, of convocation and graduation. But that is largely because it honors Dr. Verne Gallman herself. On the back of your programs, you will see a detailed history of Dr. Gallman, but I do want to just say a few words about her because she certainly was pivotal in my life, as she was probably in any of us that are old enough in this room. Dr. Gallman had quite a long and distinguished history in education and nursing education before she came to the University of Texas at Austin. And of course, in that time, nursing education was evolving from diploma programs to bachelor's programs, master's programs, and she herself received her PhD, I believe, in education in 1970 from the University of Texas at Austin. And in 1975, she joined our faculty as an associate professor of nursing. And Dean Billy Brown, I assume, hired her at that time, or brought her to Austin. She became a full professor in 1984 and retired here in the early 1990s. Before that, and at that point, became a professor emeritus. But while she was here, you know, a lot of people are beloved when they leave. I'm not sure why that is. Glad to see you go. I keep waiting. No, but she was so widely respected and regarded by her fellow faculty, but even perhaps more importantly by the graduate students that she served. And served is really the right word. There were a lot of us, and she kept us, held our hands when we thought the world was coming to an end, helped us understand that our lives would not end if we didn't get that course we thought we had to have, or helped us find a way to get in it anyway. So in the 1980s, when the university was celebrating its centennial, the regents had an option where they would provide matching funds for lectureship. And two of our doctoral students, the leadership of ANGS, the Association of Nursing and Graduate Schools, launched this initiative to acquire the funding for an endowed lectureship. That funding was then matched by the Board of Regents and has continued to grow over time. I look back at that kind of with a personal note because I was a graduate student at the time, and that was the first time I gave to this university. Not the last time, but the first time. And so I always like to challenge doctoral students and graduate students to realize what their work can accomplish. That was really it seemed like a big amount of money to us at the time, but it has grown over time. It's brought many distinguished leaders and the opportunity for us to learn and hear from them at this campus. So Dr. Gallman passed away just about 2 years ago, a little more than 2 years ago, and we miss her greatly, and we are honored to celebrate her memory today as part of this lectureship. And as part of that, we are, once again, we've had so many wonderful speakers here for the Verne Gallman Lectureship, and today we have one that certainly fits that mold, and I know will have a wonderful talk for us. And that is Dr. Suzanne Bakken, who's the Alumni Professor of Nursing and the Professor of Biomedical Informatics at Columbia University. I've had the opportunity to get to know Suzanne a little bit personally while we I'm not sure the right word, worked very hard at NIH study sections, and I always admired her ability to concisely get to the point, identify things that perhaps other people weren't seeing that were strengths of other work, and to really bring a unique perspective from an informatics perspective. Dr. Bakken completed her doctoral study in nursing at the University of California, San Francisco, and also completed a National Library of Medicine postdoc in medical informatics at Stanford. She was recruited across the country to Columbia University and has been there for a number of years. For more than a decade, she was funded through the National Institutes of Health for a Center for Evidence-Based Practice in the Underserved and Reducing Health Disparities through Informatics. She also has been funded for a pre- and postdoctoral training program and has just made so many advances and pulled so many various pieces together in unique and creative ways that I'm just so excited to hear what she's going to share with us today. She's received funding from the taxpayers in many, many ways through the National Institute of Nursing Research, the National Cancer Institute, the National Library of Medicine, the National Institute of Mental Health, and I think what this speaks to is how her work has such wide applications and uses that are important to us as we strive to improve the nation's health. Dr. Bakken has published more than 200 peer-reviewed papers, and in 2010, she received the well-deserved Pathfinder Award from the Friends of the National Institute of Nursing Research. She's an elected fellow of the New York Academy of Medicine, the American Academy of Nursing, the American College of Medical Informatics, and we're very proud to have her as one of our nursing members of the Institute of Medicine. So please join me in welcoming Dr. Suzanne Bakken.
Thanks. It's just such a great pleasure to be here. Thanks so much, Dean Steifbergen, for that, for introducing me. And it was such a pleasure to hear about Professor Gallman, and Susan Grove had given me a little bit of hints about how wonderful she was. And I believe the most important thing about what I do in my job is really focusing on the next generation. And so it means a lot to me to be giving this name Lectureship. I was reminded by former Dean Billy Brown before we were starting, reminded me that this was the place where our first journal in nursing informatics started, and it's still being published, Computers, Informatics, and Nursing, CIN, was founded here. And of course, one of the pioneers in Susan Grove, who's not only been a pioneer in the field, but she has been very much a mentor to me and nominated me for the American College of Medical Informatics. I did get in, and I now serve as its president, so I guess she betted wisely on me early on. But anyway, today it's a pleasure to be here to share some of the more recent work that we've been doing at Columbia. And so I first want to start out with a little bit of national context that may be thinking about self-management a little bit differently. And so thinking about some of the things that are going on in terms of the learning health system, how does self-management fit into precision medicine, and also the big data and data science context. I'm going to mainly illustrate some of these things through a case study of a large project that we've had funded by ARC that has focused on urban Latinos in Washington Heights, Inwood, in New York City. And so for a number of years, there's been some important reports from the Institute of Medicine that have talked first about a learning health care system, but more importantly, thinking about a learning health system, which means that's out of the boundaries of the organizations in which formal health care is delivered. And so when we see some of the different things associated with it, the importance of having a digital infrastructure, but also the importance of the types of tools that patients should have, including those that will facilitate their health management. And it's importantly to truly have a digital infrastructure that supports a learning health system. It's really important that there are tools that would be more what I would say consumer-facing, because for most of us, we don't consider ourselves patients most of the time. It's a role that we play some of the time. So it's important we really think about self-management and how we stay healthy as well. Another thing I want to just put some context, and and this is thinking also about self-management within the context of the precision medicine initiative. So Obama announced this in his State of the Union address earlier this year, and then this was followed up shortly by a paper in the New England Journal of Medicine by Francis Collins and Harold Varmus. And so although Obama is standing next to to a DNA helix if you really read the saying that goes along with the picture about personalized medicine. And if you read the paper by Varmus and Collins, you see that it truly isn't all about genomics. And those of us who are self-management researchers know that personalization is many things beyond the genes. But in the New England Journal of Medicine paper, you do see mention of really thinking about self-management strategies, the use of social media, and those kinds of things. So I think it's very important that we think broadly about precision medicine and think of it as inclusive of self-management and self-management tools, not limited to things that are gene-based. And then lastly, in thinking about big data and thinking about it from the nursing science perspective, I put up this picture of the Ucsf symptom management model. And so when we think about big data, we think about it usually from a couple of different perspectives. It's not just about volume. It's also about the variety of data. It's also about veracity of data, meaning data that might be of unknown provenance and quality, and also velocity, meaning data that changes rapidly. So in this, thinking about smart homes, sensor data, those types of things. And traditionally, for doing things such as symptom management research, we've had questionnaires, we've had different types of electronic health record data. But these days, we see various types of additional data sources. So just thinking about all the various flavors of omics. There's a lot of focus now on the microbiome, but also thinking about how environmental things, and I've even heard people now say symptom, how do symptoms fit into that? So we have these additional data sources, and then there are also the types of things that we get from mobile devices and other types of sensors that would be included, would be considered more quantified self things. These might be diaries that you're keeping on your phone or other types of things like that. And so with this variety of data sources, we end up needing new analytical methods. And so these newer analytical methods end up being a set of methods that belong to data science. So some of them there are some methodologies in common with other types of analytics, but one of the big differences is you typically are not looking at inference because you're not looking at sample data. You're really able to look at the population. And so a big thing influencing data science is the NIH's BD2K initiative, or Big Data to Knowledge. So I just want to remind people, how many people in the audience recognize this diagram? So some of them, okay. And so we say, okay, so Florence Nightingale was the first data scientist, right? Because a big part of, she took big data, she created a visualization that pulled those various data points together. And so this is her famous diagram. So we could say, nursing has probably always had a data science perspective to it. It's just not always quite as explicit as it is these days in it. So now I want to turn more to the case study, where I wanted to give you a little bit of context and then talk to you about how this context is informing our work in Washington Heights. And so this was a project that was focused on gaining a comprehensive understanding of the Washington Heights Inwood community. It's primarily an immigrant Latino community. We wanted to facilitate research with this particular population, and the other part of our grant was to create an informatics infrastructure for comparative effectiveness research and then demonstrate that utility over time. It's interesting how names of things change, and the things in italics are additional things that I believe that we've done and will continue to do, because I think a big part that I'll stress in the community engagement is when we hear about the learning health system, people talk about a fabric of trust with the community, and so a lot of of what we've done is really focused on how can we weave that fabric of trust for with our community. And now we're also providing a foundation for precision medicine, and about 2,000 of our participants will be part of what Columbia would consider its potential contribution to the million-person network that goes with the precision medicine initiative. So just reminding people, Washington Heights Inwood is the very top part of Manhattan. So this is a very skinny part. It's only about a half a mile wide. And if you look to the east, you can actually see Yankee Stadium. So we're very close to the Bronx. So as I said, this was a largely immigrant Latino, primarily from the Dominican Republic. It has a high level of health disparities, lots of obesity, lots of cardiovascular disease. So the basic idea behind this project, I want to talk first to just a little bit about the informatics infrastructure part of it, was to deeply understand the health of the community. Most of the other projects in this ARC initiative did more multi-site research, joining academic centers together. And our project was a little bit different in that our multi-site was joining together multiple clinical sites, but also considering a community as the site. So we worked with the Visiting Nurse Services of New York. We worked with skilled nursing facilities, as well as our various clinical components of Columbia University Medical Center, meaning the hospital, the faculty practice organization, et cetera. And then the basic idea in the grant was that we'd pull these resources together. There'd be a tool called a Research Data Explorer that would allow researchers to examine that data and to do research that would help to understand the health of the community in order to improve it. But one of the notions I had, although it wasn't in the original proposal, was this box up here. And that was, why are we putting all this together and then just giving it to the researchers? Why don't we give it back to the community? And I felt very strongly about this with community as data. They shouldn't just be data generators, they should be data users as well. So we decided to focus a substantial amount of attention in a follow-on grant that we wrote to ARC and also secured on doing that. So a big component of our original project was to do a community survey. So we surveyed about 6,000 people in the community. About 95% of them were Latino, and more than 80% of those were from the Dominican Republic. So one of the things that we were thinking about is the hospital data really represents how somebody looks when they're sick, and that's clearly just a piece of the puzzle. Let's see about people's health behaviors. And so these are some examples of some of the different items that we collected. In addition to having self-reported things on different types of symptoms and health behaviors, we also did research quality blood pressure, measured body mass index, did waist circumference, et cetera, those kinds of things in it. So one of the reasons I'm visiting Austin multiple times this year is for your transdisciplinary self-management center. So I just wanted to highlight in what I do as well. I feel it pulls from many different fields, and I have them listed up here. But the four I'm going to primarily focus on today is to talk about CBPR, to talk about participatory design, information visualization, and data science, and not stress some of the other elements, although they were important to our work. So in terms of thinking about the community-engaged participatory research, I showed you some of the things that we measured on our WISER survey, but it really started before that. We were one of the first clinical and translational science awards. So, and one of the things that was unique about our particular award is from the start, there was a vision that we would have a storefront community engagement center that would be outside of the medical center proper and would be more accessible to the community, because I'm not sure how it is when you come into your medical center here, but for us coming into either the hospital or to any of the schools, you have to go through security, you have to show your ID, there's a lot of things that go on. And for us, in what we're doing, some of our work is with people who are undocumented aliens, and there are many things that would possibly present barriers. And so we really wanted to be as open as possible. And so in addition to just having that constant presence in the community that's staffed by people who are bilingual in Spanish, we also had weekly blood pressure screening clinic, no pressure to participate in research. And so it was just getting started in the community with that. And then we did some focus groups to develop the survey content, and so they looked at some of the existing things. One of the areas the people in the focus group thought was not adequately covered was stress. And so we added some stress. And then we used community health workers. We did snowball sampling so we could take advantage of the social networks of the individuals that participated in the survey. We did compensation for their time to participate in research using the local businesses. And our team wore shirts. And so I'd like to say and often they'd be stopped on the street, and I'm sorry they didn't say, aren't you the people who are trying to who are improving the health of the community, but at least they said, oh, you're the people with the Bravo grocery store coupons. So they did get us. No, so it was important because it was important. So the good thing was our project was recognized. But some of the additional things we did, and I'm going to talk more about these, is as part of this, we asked people whether or not they would be willing to have their survey data linked with their clinical data, because that, once again, becomes important to seeing the whole picture, although it wasn't a requirement that they say yes to be part of it. And then we asked whether or not they would be willing to provide biospecimens. And so these are things that end up being important for both learning health system and precision medicine. And then I'm going to focus a fair amount of time on talking about the other part, is the notion of database community engagement. So we asked people whether or not they'd consent for biospecimens under 4 different contexts. And the purplish thing in the middle means there were, I think, this analysis is on 2,200 survey participants, and 1,197 agreed to everything. Okay. The numbers around the edges are people who only agreed to that particular thing and didn't agree to anything else in the Venn diagram. So in terms of, we asked them whether or not the biomarkers could be used by our team specifically for heart disease and stroke, because that was the focus of our study. We asked whether or not it could be used for broader uses by our team. We asked whether or not it could be de-identified and used by others. And then lastly, we asked whether or not it could be used for long-term storage. And then we also asked whether or not they could be contacted for future research, and whether or not we could do the linkage. I want to tell you a few things about this particular process. Our consent rates ended up ranging from about 53 to 58% in this sample, although we have a higher rate in the remainder of the sample that we're still gathering now. And the basic thing was, no surprise, the further away you get away from the original team, the consent rate goes down. And so I don't think that would shock anyone. And although I've had some people say, well, that seems like a little low, Dominicans have rarely been studied, and they're very underrepresented in research. So the fact that we would have more than half the people say yes, I actually was quite thrilled with, because these are individuals that typically would not be present in research studies. But we wanted to look at the predictors and say, well, why are some people saying yes and others? And so when we looked at, about 80% of our people were in Medicare or Medicaid. And so being Medicare or Medicaid increased the odds of saying yes. And this was our measure of socioeconomic status. And so some other studies have looked at this and typically not seen much of an influence in this. And so, but one of the things we wonder about was our financial incentives. Do people really get what they're saying yes to, or is the fact that they're being incentivized $10 for saliva, $15 for a dried blood spot? Something to think about from the ethical perspective. In terms of immigrant status, if you're an immigrant, you are more likely to consent. This was something that most people had not studied in the past, and so we'll have to see how that plays out over time. But once again, we're trying to think about this. Is it because there were bilingual community health workers and it was a trusted relationship, or once again, was the incentive important? Health, in terms of looking at health status, better health status increased the odds of saying yes across all four contexts. And chronic stress, which they'd asked to have measured, had no influence on that. The literature suggests that having a personal history of cancer has a positive influence, and so that's something that we'll be looking at a little bit more. And in terms of, I know there's a lot of people in this school interested in health literacy. So for the uses of the biospecimen by the WISER team, health literacy wasn't a significant predictor. But when you got further away from the research team, you were more likely to say yes if you had a higher level of health literacy. And our health literacy, we collected 2 measures of health literacy in the study. We did the newest vital sign, and then we also did the 3 one-item screeners from CHU. And for this particular study, the measure that we're using has to do how confident are you completing medical forms without help, because we felt that was the most directly related to the tasks we were talking about. And so we have to think about the fact that health literacy may play a more important role when you don't have that trusted relationship. So we did, so that's thinking about terms of consents and those types of things, and participation from a number of different angles. But one of the things we really wanted to focus on was a bit of a different idea of community engagement, and to think about community engagement from a database perspective. So this is when we started our initiative to give the data back to the community and to figure out how to do it well. So the first thing I did was establish a working group on visualization, and we created some infographics, and I'm going to go through this particular process with you and show you some of the designs. Then we did focus groups in the community. We did 100. We had 102 participants in the focus groups total, and about 80% of the focus groups were in Spanish, the rest were in English. We're now in the middle of a comprehension study, and then our intent is then once we feel confident about which designs will work best with our community members, then we'll start actually using them in studies. So the thing I'd point out about our visualization working group, you kind of see the formal disciplines on the right, but as it turns out, if you look at the things on your left, we ended up having a lot of artsy people on our team as well, a former apparel designer, a theatrical set designer, some artists, some landscaping. So just these different types of views that brought maybe an atypical approach to visualization and a particular aesthetic. And so we went through this very formally. We looked at the traditional graphic designs to see which ones would particularly work. We wanted to have at least 3 designs for each thing we were trying to measure. We did some prototyping and some basic hall testing with people we knew, and then we created a list of cognitive tasks and then tried to match the infographics to those tasks. So I want to share what I thought some of the goals of the infographics would be, and then just rapidly show you some designs, and then I'll go into some of the key things I believe we learned along the way. So one of the simplest views in terms of cognition was just displaying a single piece of information. And this we're trying to say days per week, or and with the icon array, looking at the proportions of fruit. We also thought that another goal of an infographic was to communicate the notion of having a particular piece of information that would have a time element to it. So thinking about the number this is for the CDC depression days measure, thinking about days of depression, days of being worried or anxious, those types of things. We had multiple designs for that. Blood pressure, and this was the need to have an infographic that would communicate a piece of information according to a criterion. So we had more of the number line one way with some different colors. So it has the actual value along with whether or not it's healthy, borderline or high, and you see that conveyed in two different ways. Because hypertension was a main focus of our particular project, we had a lot of blood pressure designs because we wanted to make sure we got that right. And so here's a couple of other designs, including a simple stoplight metaphor, which I'll talk a bit about later on. We also wanted to compare a single piece of information to the information of others. So the idea that this is your data, how does it compare to another individual's data or a group of individuals' data? And so we tried these in a number of different ways. The STAR system for looking at overall health, for sleep and energy, we used a battery metaphor, which worked quite well. And then we also used a stress gauge for chronic stress. Getting more and more complex, we wanted to be able to compare multiple pieces of information that had the same denominator on it into a single kind of report card. You can see that there. I also wanted to be able to compare multiple things in a single graphic, and I just had this idea that in the operating room, the anesthesiologist can have these graphs, and if you have a nice circle, it means like you've kind of got physiological homeostasis with it. And I just wanted to do something simple that would convey that with health status data. And so even though we had some failures in the early testing, I'll tell you that we did end up with one because I just so wanted to have a design that would do this. But you can imagine if you look at the design in the left that was not like, people didn't immediately say, yes, I know exactly what that is, and I want it. And then we wanted to also have a way to look at multiple health behaviors with different scales in a single graphic. And then lastly, we wanted to be able to display information, but then to give a broader understanding of information. And this came from one of our biomedical informatics PhD students who's also a nurse, and she said, I don't want to just show them the number. I want them to know what it means to have a blood pressure. So we tried to communicate a bit more about that, including this design that has both the stoplight metaphor, but begins to talk about, okay, what does it mean to have high blood pressure? So what are some of the risks associated with it? So we went to a lot of work to do these, and we have about 45 designs, and they're all available now if anyone wants them to try them out with their community, along with a style guide for how to automate it. But we learned a couple of things, and so one of them is more is more. I'll talk about icons and also some of this issue of comparing to others. So often in information visualization, some of the gurus would say simplify, simplify, simplify. What we really found for our population was people got this simple stoplight metaphor, but they didn't really like it. So no matter, when we did our focus groups, we separated people into groups that were supposedly homogeneous by their self-rated health literacy, and it worked to a certain extent, not totally. So there were some people who were at the lower end that had this as the preferred infographic, but for the most part they didn't. And this was the one that ended up being the favorite. And so this conveys a lot of information, but we really felt with this particular population that giving them a single piece of data in the absence of context, they just couldn't interpret it. And so they preferred what might be considered the more complex diagram, but they had no problem understanding it. And they liked the fact that you could have the number, see the various number line. We included how a blood pressure might get taken, so they'd understand that those things go together. And then in terms of the risks, we went with a strategy of wanting to put what might be considered the simpler word, but also putting the professional word. We met with Merck, I think yesterday on this, and they said, well, why would you bother? Well, it's not that we want to change the consumer's language, but we want them to be familiar with the language that might be used by others. And so we thought having the combination, the more colloquial with the professional term, and people seem to like that. So this is our design, one of the designs that we're moving forward with. So this was more is more with that. This ended up being our design for thinking about how do you compare a number of health indicators on that might be on different scales. And this notion of some people saw a clover leaf, some people saw a flower, but this notion that if everything was completely filled out, then you were good. And we found without the, if we just presented the one on the right, people did not kind of get that the unfilled out space was kind of the room for improvement. And so we needed to put the criteria next to it. And in that instance, then people liked it. They felt good about having a full flower. We learned a lot about the notion of icon arrays, and for our particular population of Latinos who were primarily Dominican, not Mexican American like you might have more here in Austin, is they were just very literal about the icons. And so we thought that tennis shoes could be an abstract representation of exercise, but people took it to mean walking. And they also had issues with with thinking about each icon representing another instance of that same behavior. And so we've ended up with virtually no icon arrays. And the ones that actually were the most interesting were the fruits. Because first we had apples, and they said, but what if Maria doesn't like apples? And then we had something that looked more like something Carmen Miranda would wear in her head. And they go, oh my God, but who could eat all that pineapple? And then you've got to eat the banana too. So anyway, we kind of, for fruit and vegetables, we've actually ended up with more simple bar graphs because those work. But there's something about the icon arrays that were not a great hit for us. We also did among our measures, we have several of the promise measures. We have anxiety, depression, that kind of thing. And so in that, we use more of this graded number line where 50 is your standardized promise score. And then if you have more of something, you have a score greater than 50. And so this is how we, what we're using for that. And depending on which promise measure you have, if your number is above 50, it might be better or worse. So anyway, you need that line below that helps you to interpret it. And that worked well with our population. People totally got the battery. Because the majority of people had cell phone batteries, so they were very familiar of the notion of running out of energy and that kind of thing. What we, once again, in thinking about how literal things are, we actually, we thought it would be very clear to say, this is your score, this is your neighbor's score, the rest of the neighborhood kind of thing. But people took it to be the neighbor. And so we've tried out some different language because they say, no, you're wrong. She has more energy than that. Or, I'm worried about her. Look how many days she's depressed. So anyway, so one of the points ends up being you really need to, it's really important. We can sit and make all these kinds of designs, but it's really important to understand your users, to try out the designs. And so we really focused on, did people appear to be able to interpret it, which of the designs did they prefer, and did they consider the designs to be actionable? But of course, you can't do comprehension in a group. And so that's why we're doing a formal experimental design with a comprehension study, and that people are given objective questions related to the graphic, and it's compared with textual descriptions, and that's ongoing. But I wanted to let you know as well, in addition to creating the designs, we're building a system that produces the designs. So we have a set of rules that come for which graphic you should use for which measure, and then we've built the system to produce that. So it takes your survey data as input, it uses the rules that come from our style guide, and then it produces the infographic. Because 6,000 people's a lot to have graduate students do individual PowerPoints. I'll have to give tailored data back to the community. So we wanted to have a system that would produce them, and that is going to be an open source. We're going to put it onto GitHub. We just need to get our infographics produced first to do that, and that will be more broadly available. Turning now to a little bit more from the participatory part of what we did to thinking about some of the data science part. So even though we had data from various clinical sites and survey data, and that by many, it feels like a lot of volume and a lot of variety for us who are dealing with handling it. But when you think about other types of data sources that would be particularly relevant for self-management, there's lots of other large volume, high velocity things that that could add to this. So thinking about what could you get out of mobile phones, what can you get out of sensors and social media, what can you get out of environmental sensors and also geographic information. One of the studies we're doing at the moment is we're thinking about built food environment. In our zip codes, we have a McDonald's that delivers And the average fruit and vegetable consumption is about 0.7 per day. And so we know in general that place does affect some type of behaviors, so we need to be aware of that. So we're doing a study that is integrating some GIS data about healthy food outlets, and then looking at notions of perceived food environment, actual food environment, and the influence of that on health behaviors. So we're getting into this a bit more, but more to come. The other thing that we've been doing, but this is not a diagram from our population, but I wanted it there to give you the idea of the potential, because our average age is about 56, and I said 80% immigrants, and so not a lot of them are tweeting. This is Twitter data, and so I don't think too many of our population are tweeting about their aerobics classes, but the point ends up being, when we really want to get a more fleshed out picture of a community, that we need to think about what are the social media sources that are available and start to take more advantage of that, because you can learn a lot from existing free sources. Also thinking from the data science perspective, one of the computational methods that's used is the notion of creating a topic model. And so the most common way you probably see that is actually as a word cloud as an example of a topic model. One of the things we did was to ask our survey respondents what were the 3 health concerns they worried most about. And so these were the things that came up. The orange things are cardiovascular disease. We have diabetes. Cancer was big as well. The thing that was surprising to us was more than 2,000 people said they worried about either HIV, AIDS, or some type of sexually transmitted disease. So I started another working group, and we're doing a lot of work in that particular area at the moment. Another data mining technique that I wanted to mention, in addition to thinking about a topic model, is thinking about some of the applying different types of data mining techniques to a variety of data sources. This is more of an exploratory pilot study on our survey data set, but the idea is to apply some of the newer data science methods to figure out what might potentially be targets of tailored interventions. So one of the things that data science methods do is they really help you hone through a large variety of variables and then be able to target some variables for your particular study. So in our instance, we just started with 925, went down to getting shorter and shorter as it being filtered through different data mining, and then went through the process to create some prediction models on it. And so in this particular analysis, what we're trying to predict both active transport, that is, just how often does somebody walk or bike or that kind of thing, but also looking at some screen time. And so what happens in these type of models is they pick the variable that separates the groups. So this is similar to, if any of you have done CART in terms of logistic regression, it starts separating the groups out. And so I think up here, we had a variable related to making time for exercise, and that ended up being important, and then having a place. And then age ended up playing out. And then one of the last predictors of amount of screen time depended on whether or not it made a difference whether or not an individual had someone else in the home that could help them with the internet. I'm assuming the reason that person could have less screen time because somebody else can do the computer for them, but it also might mean the fact that they might have more family support in the home, that they could be doing other things rather than watching TV. So we'll have to see how that plays out. I've been talking about briefly about some things in the big data realm, but I wanted to tell people that I think there are some cautions with this, and this is something that I always focus on. And so here are some of the things I worry about. It's fine. There's great promise about big data, but when we think about big data in general and big data for self-management, we need to think about whose data is missing, and particularly when we're looking at populations who are at high risk for health disparities. If you're going to look at data that only comes from smartphones, who isn't in that data set? And so there's a group of individuals called quantified self, and they tend to be highly literate, a lot of elite athletes, monitor many aspects of their daily life, and do lots of N of 1 of experiments. So when I look at that from the comparison to my wiser population, who are immigrant, have phones, but most typically primarily non-smartphones, and so they text and that kind of thing. Because we have to make sure that this focus on big data as potential data source for research doesn't end up in biased data sets and not addressing the important health disparities that we as nurse scientists certainly care a lot about. And something else we need to think about in this is, as we think about nursing science, what are nursing's important big data streams? Yes, it can be genomics, it can be quantified self. What other things should be in there so we really have the fleshed out holistic picture that nursing can bring to some of these important health disparity problems? Another potential limitation is thinking about where does theory go? And there's some interesting articles in the social science literature, like, is our field going to disappear? Patty Brennan and I have a paper under review at I think Journal of Nursing Scholarship at the moment that is focused on big data and data science and what it means for nursing. And we're actually contending that big data science should be theory-driven, that you just that theory just comes in at a little bit different place. And for those of you that heard Patty's address at the AACN in San Diego, there's a little bit of that. But so theory will, at least in big data science being done by nurses, theory should still be there. If others don't want to use it, that's their problem. But we're going to kind of do it, take advantage of our decades of work in theory development. And another kind of thing that we have to be aware of is the concern with some of these newer platforms and whether or not there's an issue with commodification of the patient data. So what I mean by that, it's fine if you're generating data and you know somebody else is going to use it and maybe they're going to sell it. There's no issue with that if you're well aware. What I get concerned about is people are providing data and then some mediator is selling those data for commercial purposes, and there's not really a clear understanding that's going on. So if you take a site like Patients Like Me, they're very, very clear about the different uses that data is going to have. But there are a number of things that the participants on those sites get by way of participation. They get sites, they get different types of reports, they get a whole series of things. And I feel with their consent processes, like, it's ethical, people are aware what they're getting into. But I'm really concerned, particularly, I don't know how many of you look through your terms of agreement for the different things you sign off, but some of them some of them can be over 60 pages long, and so I'm just really concerned about this particular issue Right now, I'm a member of the Institute of Medicine's Roundtable on Health Literacy, and we had a workshop a couple weeks ago, and I think it's probably up on the web. But when we're thinking about tasks that we what might be some next things we should do, I said I'd really like to have those famous health literacy researchers that put efforts into improving the medication packets to put some work into the terms of agreement, because I want to make sure that people who are at low levels of health literacy have the opportunity to participate in a variety of studies. I just want them to know that they're doing it at the time they agree to it. So I think we do have to pay attention. And I have another paper with Nancy Ream that's in press in the Annual Review of Nursing Research, where we look at the Belmont principles and think about big data from that particular perspective. In conclusion, there are so many opportunities coming up. It's just such an exciting time for nursing, for people interested in self-management, and they think about what's going on in big data and data science. We think about technologies. One of the new things on the horizon is the Apple Research Kit, which is really going to do a lot in terms of citizen science. And so there's a lot of ways that we can really have advancements in both the science and the practice of self-management within the context of a learning health system. We need to be cognizant of some of the potential perils with those who are at the greatest risk for health disparities. And so I think it's very important that we pay attention to that participatory research. And as always, everything benefits from having the multidisciplinary perspective or transdisciplinary perspective and thinking about who are the key stakeholders in this exciting endeavor. And with that, I'd just like to put up the acknowledgments and thank ARC and some other funding agencies who've helped to support the work that I've described. And then in terms of thinking about the broad contributions of the research team, and I'm glad, since it's the Gallman lecture, that I have a pretty good list of trainees listed who have participated in the research. And the other thing I'll say by way of advertisement, when we do our workshops this summer for faculty and students here, I'll be bringing a couple of these folks along with me so you can hear it from the horse's mouth. And with that, I'll end my comments, and we can move to any questions from the audience. Thank you. A first question. Susan Grobe, Dr. Grobe.
One of the things that amazed me was the shifting between the axes on the different visuals. And is horizontal particular to particular cultures? Circles, I can just think of the pain scale of Nancy from Colorado. You know, the circles and how full the circles are. We're very particular to different age children. So how much is there culturally in terms of access and with the circles?
And so we can't answer that because we weren't really comparing across cultures. For most of our things, horizontal worked better. However, with the battery icons, it ended up being vertical, but then it was more of an icon than yeah.
Some of those batteries were horizontal.
Yeah, and for the other, we work better that way. Yeah, so we can't compare cultures because we only primarily looked at one culture. And in much of our work, because so few people were non-Latino, that a number of our analyses, we primarily focus on the Latinos because we can find most to say. So we want to broadly share our designs so we can see if they work for other cultures and for other populations of Latinos. And so you can just contact me. We're happy to give them to anyone who wants to use them. We have our style guide, which says for this type of data, use this type of image, and that's what forms the guts of our system. And then after our ENTICE system, which stands for Electronic Tailored Infographics for Community Education, Engagement, and Empowerment, once that's ready for prime time, we'll be putting that on GitHub so that other researchers could use it and not have to start from scratch, because the intent is to share and to try to move this work forward more broadly. So we don't want others to have to do that. We want them to be able to perhaps start from our designs or learn from our methods of developing designs to use an approach to style guide, and certainly to be able to use a system that's designed to use a variety of data types and to input your own survey data and fine-tune the style guide to produce the infographics with that. Yes?
I just have a comment related to Dr. Grove's comment. I have a very small sample size, and I know that this is compared all of the studies. And I was doing this for participation purposes, and doing university standards for people. And so the pilot, we piloted in 2020, right? And the women that were helping me with the pilot, I had taken this space of this I had tried to place all of the questions and responses horizontally, so that's why Dr. Groves helped me to. And the experience, the feedback that I got was that the women told me that the women, the large multinationals put that what they call women before they did that, so they were used to being physically. They were used to seeing questions placed vertically and not horizontally, so it really threw them off to see the responses horizontally. And the women that didn't have any reading background couldn't read it anyway, and we were reading the questions to them, so that the placement of the questions went from horizontal to vertical just based on that piloting of the instrument, which we did over about 6 months. So it was kind of interesting. It wasn't really so much on the question if they were from Mexico or not, or Hispanic question, but more from SES, so they have the education and the
Yeah, and so just for the record, the comment was about the placement. It was related to the comment of is horizontal or vertical better, and the audience member mentioned that in a pilot study that was done, it was more education level rather than culture that was affecting how one wanted to see the questions to be answered. For our particular questions, all of our stuff was done via interview, and if we look at newest vital sign score in particular, the great majority would be at the level that would say high probability of inadequate literacy. And so we did it with an interview because we wanted to get data from the broadest variety of population. But interestingly, in terms of survey placement, and we're going to write about this related to newest vital signs because we've one of the former postdoctoral trainees who we snapped up as an assistant professor, when she was looking at the data, she said, these answers 5 and 6 in newest vital sign, there's something odd here. And so question 5 in newest vital signs. So newest vital signs is the measure where it's a Haagen-Dazs ice cream label, right? And so the first 5 questions deal more with numeracy. The 5th question, they say, should so-and-so, is so-and-so able to eat this ice cream? And it's a yes or no. And then the question 6 is why not? And you're supposed to say they're allergic to peanuts, and this has peanuts in it. But we found our Latino community health workers misunderstood question 5. And so, we think it does have something with the format, because they were supposed to be recording the individual's answer, and some of them recorded whether or not they got the answer right or wrong. And so other people have had some issues, and we actually have a series of papers under review that have then come back from, to have their revisions, and I've had to pulled the newest vital signs data from all the analyses, and so we're looking very detailed about, what's the risk of, to really look at the most conservative approach to use it. But for now, I'm not using it. We're just going with the other measures. So. And I think it possibly was something cultural about that, and it may have been the majority of our, I think more than 90% of our data was collected in Spanish. Yeah.
Bakken, thank you so much for a very inspiring presentation. I'm sitting here in my head, I'm writing a proposal. Inspired completely by your presentation. But I want to know if there's some other national efforts already going on. My question is related to the measurement science. So we used to, for the last 30, 40 years, we used to collecting all the questionnaire data, depression, there's 40 different depression scales all over the world that people are using different things. They try to make a sense out of it, they do comparison and contrasting, right? So last 5-10 years, the big push is, and let's use promise data set, or something that common measure that we can reduce the patient burden, but also for reduce the time and make it easier for moving our major in science. But the using of the infographic, a group of us actually in our center are working on using infographic to patient education material.
Yes.
But we haven't thought about making, that infographic as an actually effective and less biasable tool for measuring things. So I can easily think that we can convert those PAMS tools to making the tool to using infographics to instead of building like a scale. Why can't we not using that, much more clear anchor of energy bar or the whatever they're going to call? Those things are much better frame for reference. So you're thinking maybe I should, really write it to the NIH to why don't we make this as much more lower literacy accommodated measurement project nationally and use this framework. Do you know the other groups are actually working towards that, or any of your colleagues are working towards that?
Yeah, and so thinking of the comment of we have national efforts in measurement science. The big thing at NIH, common data elements, particularly thinking about the PROMIS system, the patient-reported outcomes measurement information system, which is going down to briefer measures. And so I've shown representations of the PROMIS data as a data report, and Dr. Kim's question was whether or not we should be thinking about some of these same techniques for the data gathering as well. And So I don't know anyone who is particularly working on that at the moment. One of the, although I hadn't thought about it before, just in thinking about how data science methods potentially contribute. And typically when we have a traditional database, it's the notion of what's called schema on read. And that means if you have something that fits the format, the database accepts it, and if you have something in the wrong format, the database doesn't accept it. So it means that you have to kind of plan all the variety of data to begin with. And one of the ways that data science varies is the notion of what's called schema on read. And that means that your overall data structure evolves. And so if you're getting this measure of depression, another measure of depression, your kind of database, or think about it as your giant code book, ends up evolving with new data structures as you get more variety. And so I think it is, I think there is some potential to do some things like that, and it may end up being that certain measures are good for certain types of things, such as more ecological, momentary assessment of how you're doing on a particular, say, symptom or a particular health behavior, and it may be that you need another type of measurement if you're trying to monitor the effectiveness of an intervention in a trial. So I don't have a good answer, but I think it's a very, interesting question, of course.
This lecture is co-sponsored by the Center for Transdisciplinary Collaborative Research and Self-Management Science. It's quite a mouthful, which Dr. Kim is the director of, and she has a thank you gift.
Oh, well, thank you so much. Thank you, everyone. It was my great pleasure to be here, and I know I'll be meeting with a few of you over the next couple of days, and thank you for having me. I really appreciate it.